So for anyone who is new and doesn't know who I am, my name is Rhea Markowitz. I'm from the Georgia Cancer Center, and I'm part of the hub team of the TeleDerm project. Dr. Kendall Buchanan and I will be serving as co-facilitators of our session today. So I like all attendees to put their screens on gallery view when we're not sharing slides, so that we can see each other. And I want to welcome our TeleDerm clinic members here today. So this includes the following clinics. And when I call your clinic, the PCPs can feel free to wave so we know who you are. So from the East Georgia Healthcare Centers, we have Mount Vernon, we have Soperton, Evans Health and Wellness, Baxley, Metter, Sylvania, Wadley, and our newest clinic, Swainsboro. And then we also have participants in the Phoebe Family Medicine Residency Program. So we have about 25 people logged in so far. I want to welcome our TeleDerm team. Here in the hub is Brenda Santiano and myself. And then we have logged in, we have our dermatologists, we have Dr. Davis, Dr. Rabinovich, Dr. Buchanan. We have dermatology residents and medical students. And Brenda and I, and then Kenza Mamuni, who's usually here, is off-site today, but she's out there. Thanks, Kenza. So remember to put into the chat your full name, your email address, and your affiliation, the clinic or you're a student or whatever your affiliation is. And there are examples in the chat, and I think that plenty of people have already been doing this. So now we can go over today's agenda. Next slide. Okay, so we've done our introduction. Our didactic today is going to be presented by Dr. Loretta Davis, from chair of our Department of Dermatology. And then Gabriela Duchesne, a fourth-year medical student, will be doing our case presentation today. And then we'll do our wrap-up and announcements. So I think now I can introduce you to Dr. Kendall Buchanan, who will take over today's session. Dr. Doug Patton can't be with us today. So Dr. Buchanan is a member of our Department of Dermatology. She practices over in Aiken, South Carolina at AU's Care Center for Dermatology. And those of you in the clinics, of course, know Dr. Buchanan because you're sending all of your patient consults to her. So I think, Dr. Buchanan, you can take it away now.
Sounds great. Thank you, Rhea. So we'll go ahead and get started. So as you guys know, Project ECHO is all about moving knowledge instead of people. Next slide, please. So as the goal with all of these sessions is to improve knowledge at the local level by using these distance learning approaches to help dissolve the dermatologic health disparities faced by people living in rural areas in the state of Georgia. Next slide. These are some general reminders, and you guys know if you have any issues throughout today's presentation, you can type those in the chat. We will try to resolve those as quickly as possible. So when we start these sessions, they are all recorded. We appreciate your participation in this. As a reminder, please do not mention any PHI in these discussions. And then just make sure, next slide, please. We can go on to the next slide. And then general Zoom reminders. So please mute your microphone when you're not speaking, and then always remember to unmute yourself. If you have any questions, Brenda and I will be monitoring the chat, and you can also raise your hand. And we really appreciate all the questions, you guys. It helps us to continue to decide on what topics that we would like to present, especially for next year. And make sure that whenever you turn on and ask your question, you introduce yourself. Please try to keep your cameras on if you can. We do understand that sometimes bandwidth, you do need to turn off your camera. That's okay, but we just want to see everyone's faces. And then just make sure if you are presenting today, that after you present, you stop sharing your screen so that we can all see each other's faces again. Okay? And then I will introduce, I could never say enough nice things or great things about Dr. Davis, because she's honestly been the best mentor I could have ever asked for. She was my chair and program director when I was a resident. And as most of you know, she has been here at the Medical College of Georgia for over 30 years. She started here as an assistant professor in 1992. She's risen through the ranks and became chief of the Division of Dermatology in 2010, and then became the founding chair in our new Department of Dermatology in 2019. So we couldn't be more grateful for her. I have a feeling this is a lecture you're going to want to watch over and over again. But with that said, Dr. Davis, I'll let you take it away.
Thank you, Kendall. It has been an honor to be part of this department for that long. And so it's going to be fun, hopefully, to share some of my knowledge that I've learned as I've gained these gray hairs. And because I'm not technologically really advanced, Jennifer Sue, my resident, is here to help me share my slides. So we'll see how this is going to go. Right. And then share. Are we good? Yes. Can you see my slides? Yes?
Yes.
Yes.
Okay. Thank you very much. Well, it's a pleasure to talk about rashes in creases, or the intertriginous rash, for the next 20 minutes. You would think this is not something we see often, but it's something we see every single day, I believe. Let's see.
So I think that is
Let's
their
see.
screen.
So,
That's not our screen. So if you just press the arrow button, yeah.
okay, click. So we're going to start off talking about intertrigo, which most people think is just a common heat rash. And this is the only slide that I have pictured that's not my own. We just don't take pictures of it because it's just that common. It's something we see every day. And the culprit when it comes to intertrigo is moisture. So friction plays a role. Usually people have skin rubbing against skin when they're walking, but it's the moisture that's between those skin folds that causes this irritation, redness, and misery. It's usually beneath the breast, under the abdominal pannus, or in the inguinal folds. The skin is red, it's macerated, and it can actually heal quite dark if when it heals, and then it starts over again. So it tends to be a chronic issue. And you can see in this picture, it almost looks chafed. Can you see my cursor? Okay. Yeah, it looks a little chafed at the edges. And in this one, you can see it's healed very dark, but that doesn't mean there wasn't inflammation there before. Now, I think the important thing to realize is that this is not a yeast infection. This is not Candida, but it's a setup for Candida. So intertrigo by itself is just irritation. I'm going to talk about how you treat it. But in the current pictures, this is not yeast. However, it will invite yeast if given the opportunity. So there is Candida intertrigo. So once you have intertrigo, then yeast may decide to join the party. So when there's yeast, it tends to be very beefy red. And the other thing that you see are these little satellite papules at the edges. Okay, so these little satellite papules were not in the previous picture. Okay, and those little satellite papules are the yeast. And you can see budding yeast here if you did a KOH exam. So why do some people get yeast in their intertrigo and other people not? Well, if you're diabetic, you're prone to yeast. If you're overweight, you're more likely to get yeast. If you've completed a recent course of antibiotics, then yeast takes over because the bacteria aren't there to the same degree. Systemic steroids will cause yeast infections. And then we, as dermatologists, prescribe all these IL-17 inhibitors for psoriasis. They predispose people to yeast, and so do the SGL2 inhibitors that are used for diabetes. So there's a lot of different things that can cause patients to have secondary yeast infections. Now, one really good teaching point is that intertrigo likes the creases. Yeast really likes to jump onto the scrotum and the vulva, okay? And so what you're seeing here, oops, let's see, go back, okay. But it really likes to get onto the scrotum. And occasionally can be extremely widespread. And this lady who was in the hospital for several months getting antibiotics, you can see that she's got yeast in all of her creases. Another interesting thing that I don't think people realize is that you can get yeast between your fingers and your toes, okay? Because that's a crease. And even though you don't see the satellite papules here, you see this white change just like you would see in the mouth if someone had thrush. Okay, so that white change, if you KOH that, that's got yeast there. And dermatologists love to give things complicated names so we can impress everyone else. And so the name for this is Erosio interdigitalis blastomycetica, which means erosions between the digits that someone thought looked like blastomycosis, but isn't. Okay, so it's just yeast between the fingers, and that can be quite miserable. And people who get that usually are people who have their hands in water all the time. So people who do janitorial work, or people who work in cafeterias, people who, are scrubbing and they get water between their fingers and they don't let it dry out. And then people who have contractures of the fingers. So I've seen this commonly in people with rheumatoid arthritis, for example, who just can't spread their fingers apart anymore because they're so contracted. So Candida between the fingers. So when you're treating intertrigo, the main thing you need to do is get rid of the moisture. Okay, so after you take a shower, you want to dry off well. You might want to take a blow dryer and put it on the cool setting and blow dry your creases. You want to wear gloves when you're doing wet work. You want to avoid fabrics that retain moisture. So silk and polyesters retain moisture. So when you exercise, maybe cotton would be a better choice. And the big thing is you want to avoid moisturizers that are moisturizing. Okay, so if you put anything on, you don't want to add a cream to something that's already moist. Creams are made to moisturize. So why would you put a cream in something that's already moist? So instead, use lotions, because lotions are drying. So what we typically do is use a low potency steroid lotion in the creases, usually hydrocortisone, which is generic, is fine. Do that twice a day for up to 2 weeks if you need to use it that long. Stop earlier if you get done, and then if it's better, and then just start up again if you flare. We love powder because powder is absorbent. And again, if it's just intertrigo, any powder will be fine, an absorbent powder. But if there's candida, you're going to add a powder that has an azole in it. So clotrimazole, miconazole, econazole. Azoles are good for yeast. Or you could add nystatin. Again, don't use a cream. Why would you put a cream in something that's already moist? You're going to use powder or lotion, and that's going to be much more effective. So powders. Okay, so let's talk about yeast versus dermatophyte. Is there a difference? Is it a big difference? Does it really matter? It matters. Okay, so in Candida, intertrigo, what did I tell you? You're going to see little satellite papules, right? Okay. In Tinea which is dermatophyte, instead of the little satellite papules, you have a well demarcated advancing margin. Sometimes it's a little more elevated, it's a little scaly, okay, but it's a well demarcated, draw a line kind of margin. They look very different. The other thing is Candida intertrigo loves the scrotum and dermatophyte does not. And that's real helpful too, because if you're going to treat someone, you want to treat them for the right problem. The other thing is, because we call this jock itch, people think only men get it. Well, women are very athletic. We see in a lot of women too. So women get tinea as well. And again, it's not macerated. It's scaly. You see the scale here. It's all the way throughout here. And it has that sharp advancing margin. And here you can see not only is the margin very sharp, but it's a little red and it's a little elevated. And that's where, if you're going to do a KOH, you're going to scrape that advancing edge. So they look very different. So with dermatophyte tinea, it's got a well demarcated margin. There's scale at the advancing edge. And what you want to do is kill the fungus, right? So you're going to use a fungicidal cream. And those are the allylamines. They end in fine. You can get terbinafine, butenafine over the counter. Naphthafine is a prescription. So you want to kill it straight out. Use those drugs twice a day for 2 weeks and it should be gone. Cyclopyrox is also fungicidal. You can use an azole, they end in azole, but they're static, meaning they have to die of old age, which means you might have to use them for 3 or 4 weeks to really get people better. So that's why it's important to know the difference. You're going to use an azole for yeast because the allylamines don't work very well. Okay, but if you really know someone has tinea, you're going to use a fungicidal product, and those are the allylamines and cyclopyrox. Now, tolnaftate's available over the counter, and it's fungicidal and fungistatic. For some reason, we don't use it very often. Finally, if terminal hairs are involved, so sometimes men, especially in the groin area, there'll be terminal hairs and the creams just aren't working, and that's because the fungus has gone down the hair shafts, then sometimes you have to use an oral agent. An oral terbinafine would be our favorite, although you can use one of the azoles as well. Okay, and then if you're looking at it under the microscope, instead of those budding those yeast forms, you're going to see these long hyphae that look a little birefringent green under the microscope. If you're not sure if it's Candida or tinea, then use an azole or cyclopyrox because they treat both pretty darn well. You just have to use the azole longer. You have to have a high index of suspicion for tinea. So a lot of people, I've seen people treat the front because they knew that was their jock itch tinea in the front, but didn't realize it was creeping up their backside. So tinea likes to creep up the backside and it'll be on the buttock sometimes. And again, you can see it's scaly here. And then it can show up in unexpected places, like this gentleman who thought he was allergic to his deodorant, except that it's got that super sharp margin, right? A really elevated sharp margin. And that is dermatophyte in a funny, unusual spot. So the saying in dermatology is, if it's scaly, scrape it and look under the microscope. So let's talk about that, KOH examination. So technically what we've done is we take a 15 blade or glass slide and we scrape some of the scale onto the glass slide, and then we put a little drop of KOH, put a cover slip on it, and then smash it down, mash it down, so that you have a thin film of cells, and then you gently heat it. Well, this is the way we've done it in the past. Well, most of the time, if it's this classic, you might not even do a KOH, but you might do a KOH for this when you're not sure. And so even though that's what we've done, we're not allowed to have flames in the clinic anymore. So that's against the rules. So what we do nowadays is we take this suspicious spot, we scrape it, and we put it on this glass slide, and we just put it on our microscope right over the light where it gets hot over time, and it gently heats it. And I tell my patient, I'm doing an in-office test. If you want to know what this is before you leave today, if you give me 10 minutes, I'm going to go see another patient while your skin dissolves. And then, you know, it's easy to see the dermatophyte because the epidermal cells have dissolved with the KOH. And if the patient hears you talking to the next 2 patients, they are not upset because they know you're doing an in-office test that's going to be helpful for them. And then I put a little sign up there so they don't throw away my slide because I have nurses who are really good at cleaning up. So that's what we do these days, looking for our dermatophyte. Okay, so this one's a little scratch your head. You look at this, it doesn't look exactly like dermatophyte or yeast or intertrigo. It really looks odd. Okay, so you can see it's been going on because it's hyperpigmented. It's healed dark in areas where it had been. You can see there's scale right here. There's scale over here. It's still pink, so there's still inflammation. So why is that? Well, this is tinea incognito. So it's altered tinea. Okay, and this is what happens when you put topical steroids on tinea. The topical steroids help get rid of the inflammation, but the tinea is still there hiding out, and it's not gone, and it's still causing misery. So one of the reasons we see tinea incognito is because of combination drugs. So for example, nystatin mixed with triamcinolone. I'm not sure why these things are invented because I've never prescribed them, but they're common and a lot of patients use them. So nystatin's for yeast, so that doesn't make any sense because this is tinea. And the triamcinolone is so strong that it gets rid of the inflammation, but it's the Candida loves it. It's a great environment. So it's, like yeast on steroids. And the other thing that we see is clotrimazole with betamethasone. Now, betamethasone, dipropionate, is a class 2 very strong drug, and it does the same thing. It's too strong to allow the clotrimazole to get rid of the fungus. And remember, I said clotrimazole, it's fungostatic and not fungicidal. So those things kind of make it look altered and not quite right and just perpetuate the agony. So we do not like combination drugs. The other problem with combination drugs is that the steroid is strong and it can cause atrophy. And so people will get stria in the groin area and that doesn't go away. I actually have had patients tell me, I keep using this medicine and the rash is just getting worse. Well, they were using it on the stria, expecting the stria to go away with the creams. So you really don't want to use strong steroids in creases for very long. And this chart is taken from the Eczema Foundation. Class 1s are super potent. Class 7s are what we typically use, but usually only for intertrigo, okay, and not for tinea. There is no reason to use a steroid for tinea at all. They mix the two together because it helps the itch get better a little faster, but it's totally unnecessary. Okay, the other bugaboo that I don't like is someone who's been here a while is the pound jar of topical steroid, okay? Because that means that patients think they can just spread it in their palms all over their body, and so they're going to absorb a lot of steroid instead of using the fingertip method, which is what I like. So in my opinion, there's no reason to give someone a pound of anything. Okay. The other intertriginous thing that we see is tinea pedis. So there are different varieties of tinea pedis, but the tinea pedis, the fungus dermatophyte between the toes, is probably the most common thing that we see. So, we've got jock itch, and then we've got this quote athlete's foot, but you don't need to be an athlete to get athlete's foot or tinea pedis. Now, a lot of my patients will say it doesn't bother me, you don't need to treat me, and that's fine. But you do have to be aware that some patients will have this, and next thing you know, they have these erosions like you see here, and you can see she's got red here along the cuticle. She's got a staph paronychia, and with looking at that finger, I'm real concerned she has a staph infection now between her toes. Okay, so just remember, tinea pedis is an entry point for bacteria, okay? Bacteria will jump in the cracks that the tinea is causing, and you can get a Staph aureus infection like you have here, or you can get cellulitis. So in people who are at risk for these things, you want to treat their tinea pedis aggressively. That would be your patients who have diabetes or lymphedema or a history of cellulitis. You want to be mindful of that and treat their tinea pedis and maybe even the fungus in their toenails as well. Okay, finally, we're going to talk about another intertriginous rash. And my patients are great. I told them that I was going to be giving a talk. Would you mind if I took some pictures? And the next several folks said, please do. I want people to understand how miserable I've been because I wasn't diagnosed. So this patient said she had itching and burning for many months in the genital area. She was very uncomfortable. And so this should be your thought process. Okay, is this intertrigo? Well, not really, because if you look, it very much involves the genitalia. It's on the vulva, and the crease here is actually fairly spared, okay? So I told you intertrigo should be in the crease. But this is really more on the vulva, and the crease in this case is not that impressive. Is it yeast? Well, I don't see any satellite papules, okay? No satellite papules or pustules. That's probably not yeast. It's not really macerated right here. It's not shiny and moist right here. And she has no risk factors for having yeast. Is it tinea? Well, I don't see an advancing margin. I mean, this looks the same throughout. No advancing margin. It involves the vulva, which usually yeast does not do. She's not been putting any topical steroids on it to change the picture. Okay, what do you do next? Well, what I would do next is where else might she have it? Remember to do a full skin examination on some of these folks when you don't know what's going on. Okay, well, let's look. I just happened to notice her elbow. She's got this scaly, maybe more of a patch on her elbow. So I don't think it's diagnostic, but it does make me think of one of my favorite diagnoses. It just happens to like elbows. And so looking at her elbow, I want to ask her, well, where else do you have this? Do you happen to have this in your intergluteal cleft, okay, or the crack of your buttock? And surely she does, okay. And when you look at this, okay, it is a plaque, not a patch like you might see with intertrigo. There are no satellite papules, and it is scaly, okay. So remember, the most common papulosquamous disease, a red plaque with scale with a real sharp margin, happens to be psoriasis. And this is inverse psoriasis, which is not rare, but oftentimes overlooked, misdiagnosed, and patients go on for months because people assume it's yeast. Okay, so inverse psoriasis means that instead of being on the flexors, okay, instead of being on the extensors, the elbows and the knees, it's on the flexors, it's in the creases. In this patient, I said, well, let's look at your other creases. So we looked under her arms, and she has one solitary papule in her right axilla, well demarcated. That does not look like intertrigo. It's a papule. She doesn't have one papule of yeast, does she? Okay, and dermatophyte, one papule in the underarm? I don't think so. And then, of course, since we do dermoscopy, I had to show this for Dr. Buchanan, Dr. Rabinovitz. We did take our dermatoscope because I think it was just a good way to show how red this spot was. I mean, you don't really appreciate it in this, patient with a Fitzpatrick type 5 skin, but boy, you can really see it here with dermoscopy. Okay, it's really red, and you can see their scale. So in dermoscopy, even those of us who aren't expert can say, well, that's a scaly spot, and there are a lot of red dots even on this poor quality picture. So that is consistent with psoriasis as well. This is another patient, okay? And this is a pediatric patient, preschool. This little boy's been suffering with this for several years. It hurts. He can't exercise. He can't play with the other kids at school. And you can see he's becoming overweight. Well, if you can't exercise and it hurts, that's going to happen. So, and that, that's self-defeating. And so if you pick up his pannus, he has this telltale fissure right here. So these eroded fissures are very common in inverse psoriasis. He's got exactly what we talked about, a well-demarcated plaque, no satellite papules. I've never seen intertrigo in a preschool child, and I've never seen tinea cruris, before puberty. That is something that happens later. So the fact that this is happening in a young child, you really need to be thinking about psoriasis. It's not an eczema. It's got too sharp a margin. Eczemas, remember, have poorly defined margins. This is psoriasis. Where else do we want to look? Oh, the other point is, psoriasis is part of metabolic syndrome. And so we see psoriasis in people who go on to get diabetes and hypertension. And so this is just not really good for this little boy who's overweight. And then you also ask about family history, because sometimes that helps you make the diagnosis. So where else do we look? Of course, we look in the gluteal cleft, and sure enough, he's got it. You can see the scale here. You can tell he's been scratching a little bit. Look at his axilla. He's got a plaque in there, well demarcated. And in addition, he's got that little teeny crack, that little fissure that tells you this is inverse psoriasis. Those little painful cracks are very characteristic of inverse psoriasis. Where else does he have it? Well, look at the belly button. He's even got a little fissure in his little belly button. Very uncomfortable. And then you look at the knees, and he's got a little bit there, but that's not the prominent thing that you're seeing. He has inverse psoriasis, which again, I think is just, I feel like I'm spreading the news because we see it fairly often. I've seen probably 5 cases in the last couple of weeks. And I think just people, it's been the lost child when it comes to psoriasis. So with inverse psoriasis, how are we going to treat that? Well, he came in using nystatin ointment. Now we know that that's not going to helpful because that's not yeast, right? And he had mupirocin ointment as well, and that's for superficial staph infection. So that's not going to help. So we don't need that. We used hydrocortisone ointment because it's dry, it's scaly. So in this case, we want to add moisture, 2.5%, and we'll use that for a couple weeks and then maybe just twice a week after the first 2-3 weeks. Calcineurin inhibitors, tacrolimus and pimecrolimus, are very excellent for inverse psoriasis. They're actually FDA approved for eczema. They're safe. They work well for inverse psoriasis. Calcipotriene ointment is FDA approved for psoriasis, but it doesn't work as well, quite honestly, as the calcineurin inhibitors in the creases. We have a lot of new drugs on the market. They just approved a PD4 topical cream for psoriasis, an aryl hydrocarbon receptor agonist for psoriasis. A lot of exciting things on the future. These are expensive and insurance doesn't tend to pay for them. A lot of these, Primulast is an oral PD4, but it's not approved for kids. It does help some adults. We still use methotrexate sometimes, and we have biologics. And I have a feeling this little boy is going to need a biologic to get rid of his disease. And some of those are approved for his age group. So the other thing in an adult you're going to ask about, are you taking any medicines that might make psoriasis a problem? Beta blockers are the big ones that we see because so many people are on beta blockers. Obviously, we are not going to stop beta blockers as a dermatologist, but we might talk to PCPs and say, you know, the patient can take a different antihypertensive. It might be very helpful. NSAIDs can keep it going if you take a lot of NSAIDs, and of course, lithium and hydroxychloroquine. Okay, so my favorite teaching slide of all times is this slide. So I'm going to share this with you, and that'll be the end of my talk. But let's talk through this real quickly. So this patient came in, she's miserable. She has had a problem, quote, down there that she's been treated for yeast for years. And it's a well-demarcated plaque, right? Sharp margin. In fact, what she has is one large, well-demarcated plaque. No satellite papule, so this is not yeast. She has no scale in the creases, and that's because her pannus hangs down to right here. Okay, and that's where her abdomen hangs down to. So she's self-moisturizing in this crease. And where her pannus ends, you see the scale of psoriasis. So when it's inverse psoriasis, oftentimes you don't see the scale because it's in the crease. Okay, creases provide moisture. Scale is beyond the pannus in this picture. And look at her fingernail. She's got onycholysis. So again, examine the entire patient when you're making a diagnosis. Ask them to see their private parts that they might not want to share with you because the answer might be there. Look at their fingernails. Ask about joint pain. This patient had inverse psoriasis. This is really easy when you go through that logical thinking. And the take-home points then are everything down there is not yeast. Intertrigo is invited in. Okay. Intertrigo invites yeast into the party. Okay. Yeast is invited in. Use lotions and powders for yeast and intertrigo. Use azoles and cyclopyrox, okay? If you want to treat something, if you're not sure and you want to treat both yeast and tinea. Allylamines are fungicidal, so they're better for tinea. Avoid combo drugs. In my opinion, they should never have been invented, but that's my opinion, but it's a strong opinion. And sometimes psoriasis really prefers your creases, and then we call it inverse. And that's all I have. Thank you. And I will stop sharing my screen if I can figure out how to do it.
Great. Thank you, Dr. Davis. That was wonderful. And I think very appropriate for this time of year as the humidity goes up and we start to see a lot of irritation due to moisture and friction. So thank you very much. Those tips are great. And I think we do have one question. I see one hand from Kenza, or maybe that's a clap.
Oh, okay.
I think somebody did raise their hand, but I don't see any hands raised now. Do you, for inverse psoriasis, you know, we're always, you know, a little bit cautious to use topical steroids initially, especially in those areas. Do you have sort of a regimen that you prescribe for like limited areas of inverse psoriasis other than topical steroids?
So, you know, I will use that 2.5% hydrocortisone for maybe 2 weeks, and then on weekends, I really like tacrolimus ointment. I think it's safe. It's a steroid substitute. It can't hurt you. I think that's very helpful. We tell people to keep their creases dry, and, you can use powders. I think that the topical vitamin D medicines aren't quite as helpful, but sometimes they need it for their elbows at the same time. I've saw someone recently, and the topicals were doing great. So, you have to have people who stick with it. When you have it in so many areas, like some of the people I've shown you, I think eventually they're going to need a biologic.
Okay. Thank you. Does anyone else have any questions before we move on to our case presentation? Okay, so I'll introduce Gabriela. She is a third-year medical student. She's gonna present on, we're switching gears here. She's gonna present on a case that was submitted through our consult service, and we're just gonna go through this case. Her and I discussed it in a lot of detail, and we think it just provides a lot of value in terms of the kind of images that you guys are seeing and what we're seeing in our clinic as well. Thanks, Gabby.
Thank you so much for the introduction, Dr. Buchanan. Are y'all able to see my slides?
Yes.
Okay, excellent. So my name is Gabby. I'm a fourth-year medical student here at MCG, and today we'll be presenting an interesting case consult. But before we start, I just wanted to thank Dr. Buchanan for her tremendous contributions in the creation of this presentation. And so our patient was a 53-year-old female with a history of non-melanoma skin cancer whom presented via TeleDermatology e-consult with concerns of a changing red scaly nodule on her right posterior lower leg. And so the nodule had been present on her ankle for multiple years. However, she had noticed some growth in the lesion and also had some concerning associated symptoms of bleeding, scaling, and crusting, which can be concerning for malignancy. And so on examination from the clinical image provided, we observed a dome-shaped red to pink nodule with significant scaling. And given her history of previous non-melanoma skin cancer, the associated features, as well as the clinical appearance of the nodule, we were concerned for malignancy, particularly squamous cell carcinoma, but our differential included basal cell carcinoma, keratoacanthoma, and dermatofibroma. And so here we have our dermoscopic image that was taken via mole scope. Unfortunately, it is difficult to see all of the features of this lesion beneath the diffuse scale, but we can highlight a central hypopigmented area with shiny white structures. We can see a brown structureless area with scale in the periphery of the lesion, and we can also observe focal dotted vessels. And so while on our clinical image, we could appreciate a pink color on the nodule, we see very little of that in this image, which is likely due to too much pressure on the nodule blanching out the pink color of the vessels. A little tip that Dr. Buchanan has shared with me to prevent this and improve the quality of the images is just using some type of gel, whether it be ultrasound jelly or even hand sanitizer, as a barrier between the lesion and the dermatoscope. And so judging from these images and history, it is very important that we consider malignancy. We see here that clinically our lesion presented very similarly to squamous cell carcinoma, which typically presents as pink to red nodules or plaques with scaling. And here we see some characteristic patterns of squamous cell carcinoma on dermoscopy. In our lesion, we can identify yellow scale as well as dotted vessels, which we can see a little closer on this next slide. And so while dotted vessels are smaller than the glomerular vessels in this animation, both can be seen in squamous cell carcinoma. And we also appreciate the yellow scale present in this image. And so at this point, given our clinical images and history, we see a dome-shaped red-pink nodule with significant scaling and crust concerning for squamous cell carcinoma. However, it is very difficult to distinguish given the scale overlying the image. And so a great teaching point that was recommended in this case is that actually scale obscures underlying structures and can hinder complete evaluation. And so it can be extremely helpful to make sure to wipe away any scale from the lesions with an alcohol wipe before capturing images. And so our patient was initially referred to Wellstar MCG pigmented lesion and skin cancer clinic for further evaluation, as well as for possible biopsy to rule out malignancy. And when we saw the patient at clinic, we were able to use an alcohol wipe to wipe away a significant amount of scaling. And then after doing so, we noticed a significant difference in the appearance of the nodule, which we wanted to highlight here. And so now we're able to appreciate a firm pink nodule with peripheral brown pigmentation. And I wanted to mention that this image here, as well as the following images, were captured with a Casio camera. And so here we have a polarized dermoscopy image, which was made after the scale was wiped away, where we can much better appreciate the focal dotted vessels with background central erythema, a peripheral reticular network with homogeneous brown color, as well as diffuse shiny white structures. And so we wanted to highlight the huge difference that was made by just wiping away scale with an alcohol wipe. So on the left, it's very hard to see the underlying structures as well as the colors of the nodule, and we predominantly only see scale. But then on the right, we start to see a pattern form. We can see a central pink-white area and a peripheral network. And so using the Casio camera, we were able to take multiple photos of the lesion and wanted to highlight features of the nodule with different types of light, including polarized, non-polarized, and near UV. And so the near UV image highlights the central white scar-like area with a peripheral brown network the most clearly. And these are actually features that are classic for the diagnosis of dermatofibromas. And so we wanted to introduce the TADAL algorithm, which is another triage algorithm which is very helpful in determining whether a skin growth should be monitored versus biopsied. And it's actually different from the two-step algorithm that we've traditionally learned in that it begins with determining whether a lesion is an angioma, a dermatofibroma, or a seborrheic keratosis, before continuing to identify architectural disorder, such as asymmetry, concerning colors, structures, and then patterns. So using this algorithm, we were actually able to very quickly identify that this nodule is likely a dermatofibroma. And so instead of biopsying the lesion, we were instead able to reassure the patient. And so dermatofibromas are common benign skin growths, which are often attributed to skin trauma, including insect bites, folliculitis, or vaccinations. And while they are typically asymptomatic, they can be associated with pruritus and tenderness. And they classically exhibit the Fitzpatrick dimple sign when pinched, as we can see in this image. And so they are commonly found on the lower leg, just like our patient. And while they can be solitary, it is not unusual for them to be present in multiples, which was actually the case in our patient as well, who had another lesion on her left leg. And so on dermoscopy, dermatofibromas classically present as this central white network or scar-like patch with a peripheral pigment network or peripheral homogeneous pigmentation, as we can see in this image and here. And then on this slide, we can see some examples highlighting the shiny white central scar-like patches with peripheral network of pigmentation that we typically see in dermatofibromas. So in summary, we thought that this would be an excellent case to highlight both the strengths and weaknesses of teledermatology, which have actually been a huge topic nationally. When successful, e-consults improve access to dermatologic care without additional patient travel. And they can also expedite care for concerning cases through triage. However, the success of these e-consults depends directly on the quality of image provided. In our experience, the main reason why e-consults fail is insufficient image quality, an unclear location of skin location, and a suboptimal accompanying history. Excitingly, we have consult platforms which are working on incorporating AI image quality optimization, in which the consult platform, such as Derm Engine in our case, would be able to detect problems in images before they are sent. And so as we finish up, I just wanted to share some helpful Molescope tips and tricks which can assist in obtaining a great image. And so first we have just always remembering to clean the iPhone camera lens and Molescope lens with alcohol before capturing images. And then also remembering to remove scale from skin lesions using alcohol wipes, and then also using gel as a barrier between the mole scope and the lesion in order to reduce blanching and improve focus of the image. And so I wanted to thank y'all all for your close attention. And we wanted to complete this case just a few minutes early with a discussion highlighting the barriers that you all may encounter while using mole scopes in clinic, as well as just welcome any questions for the TeleDerm team. Thank y'all.
I thought that was great, Gabby. I also wanted to say that I've seen Dr. Buchanan got one of these little like droppers. I know my blur is on that have 70% alcohol in them, and use that to put on your mole scope and then put on the lesion. And that's been really helpful too. So if you don't have alcohol pads or find that easier.
Gabby, do you mind stopping your share for a minute?
Yes, that's right. That's what I'm trying to do.
Thank you.
I can figure it out.
But yes, alcohol droppers can be really helpful. I know Dr. Rabinovitz had mentioned that we'll hopefully try to get some of the alcohol spray bottles from the American Dermoscopy Conference that is taking place this summer. And so I keep one of those in every room and just fill it with 70% alcohol. Because the alcohol wipes, I haven't found, especially if you're taking photos, sometimes they can leave streaks on the images. A lot of times I'll use that just to get a quick glance at something, but if I need to take a photo, then typically I'll use just like regular ultrasound gel. Or you can also use alcohol gel, although that can sometimes have bubbles, more bubbles. But mainly this case was just to kind of highlight the differences that we see when you have a lot of scale versus when you use alcohol or some sort of fluid interface to reduce that scale. And this was a really challenging case. This was not like your classic, cut and dry dermatofibroma. So, this was a very appropriate case for referral. This patient actually had precancerous lesions that we were able to treat as well that same day. So, again, this was not, this was just meant to kind of share with you guys the differences that we see when we do use alcohol, and how important that is for me to be able to provide the best feedback for you so that we all benefit as well as our patients from using this platform. Do we have any other questions? Looks like we're pretty good on time. If anyone has a question, or we just kind of want to understand the barriers that you guys are encountering. We have been seeing some more consults, and we do appreciate that. And, any of these consults are welcome. If you have a question about the feedback you get from your consult, or any questions about referrals, we're more than happy to help you with that. So we just want to really emphasize that we have a great support team. We're here to help you guys. We just want to kind of know how we can better meet your needs so that we can continue to grow this platform and continue to work together like this. Oh, something's in the chat. Oh, it might just be from Brenda.
Hey, Dr. Buchanan, I got a question.
Yes.
Hey, so when we do the referral to you guys, we are having some trouble getting the uninsured in. So like we're having to send the referral, then they have to have something stating that they were seen via the TeleDerm module before they can even send it to your all's office or something. Does that ring a bell?
It does not, but I can check with our nurse scheduler. We've essentially been trying to put these patients, especially if they have a concerning pigmented lesion, in one of our pigmented lesion clinics. And I can talk to our nurse scheduler and Dr. Davis, you might have more insight here too, but I think from our end as well, because these patients might not always be seeing myself, and I'm the only one that's answering the consult. So I think that's a great point, and that's something that we need to work on, because not all the other providers, like Dr. Potter messaged me about another patient that she was seeing that was referred from the platform, but she didn't have access to Derm Engine. So, then I'm having to look it up and send it to her, which is, easy enough. But I do think we probably need to stream that process a little bit better so that we can get these patients in quicker. So I'll work on that, Kyle. And you've been sending in a lot of consults and really appreciate it.
Thank y'all.
All right, well, I'll turn it back over to
I
Rhea.
had a question.
Have
I put it in the
something.
chat.
Oh.
So Dr. Sheldon. So for me, one of the biggest issues is recognizing the distinction between serious and not such serious lesions. And on the one hand, you don't want to miss something that's important, and the other hand, or serious, and the other hand, you don't want to overuse the format either. And my background is I spent most of my time doing inpatient work, so it's not like I dealt with a lot of dermatology inpatient. You just, it's got to be like a Stephen Johnson or something very serious before that happens, and that I do recognize. But there have been lesions which I go, oh, that didn't seem so serious, and oh, that turns out to be a basal cell, or where so that's just sort of getting that experience, I guess. And I mean, you're all in the dermatology holics, or however you want to put it. I mean, you love this stuff. For the average PCP, there's still a lot of sense of unfamiliarity. It's the reason why we use the steroid with the yeast review, because we're not really sure, and we're playing the odds. And thank you for clarifying why you wouldn't want to just do it that way. But that maybe you could talk to that point in terms of being more comfortable with recognizing serious versus not serious.
So there are lectures on the TeleECHO site on neoplasms of the skin, both benign and malignant. So all of the benign neoplasms, whether it be seborrheic keratosis or lentiginase, are on there in terms of a formal lecture. And there are also lectures that are formal lectures on both basal cell, squamous cell carcinoma, and melanoma, as well as some introductory lectures to dermoscopy. So if you have time, they're really, really good lectures just to review. And then on the TeleECHO site, the first year are teledermoscopy lectures on almost all the neoplasms of the skin. And dermatology is really based on pattern recognition. The more you see the patterns, the more you become comfortable with them.
Right.
So the best way really is just to take a look at as many lesions as you can. And when questioned, send those to Dr. Buchanan. Particularly lesions on the face. I think the most important lesion that is very hard to distinguish, and even for us at times, is when you have a flat, isolated pigmented lesion on the face. Because the differential always is melanoma on sun-damaged skin versus a benign lesion like a lentigo. So any of those isolated pigmented lesions would certainly benefit from a consult with Dr. Buchanan.
Yeah,
Yeah,
I was gonna second that. Oh, I was going to second that too. I mean, I think that's exactly what this service is for. If you're not sure, send it our way.
yeah, and
Something went
really,
wrong. Please try again.
anything like Dr. Benovitz said on sun damaged skin, anything that's painful, that's raised, is something that's, I find a lot of the times patients with squamous cell carcinoma, especially if it's a nodular or keratoacanthoma type, will complain of a lot of pain. And then, always like the wound that doesn't heal, like something that you continually see over and over that's not healing. Sometimes that can be concerning for like a ulcerated basal cell carcinoma. And then Melanoma for sure. You know, we go over the ABCDE criteria, which sometimes confusing because all seborrheic keratosis have multiple colors and weird borders and look abnormal to a lot of people. But please reference our lectures, and you know, I'd rather have more consults for seborrheic keratosis than not enough consults. So I will never get mad for diagnosing a seborrheic keratosis. So
Well, good. Okay, because I don't want to get you mad because you have a nice, that's the last thing you want to do is get your consultant mad at you. And I'm sorry, where is the best? Where you mentioned referencing those resources. What's the quickest way to get to those?
I think
They
Brenda in
The,
the chat.
um, Brenda just put the links for that in the chat. So we have our website is, it's augusta.edu/cancer community. It's a long thing. So we have the teledermatology website, and there are these lectures that are, that all pretty much by Dr. Rabinovitz that he mentioned, and they're on the provider page of the website. And actually you can, if you enter them in the correct way, you can get CME for watching those. And then also there's a link for the Cancer Center's YouTube channel, which has all of the previous TeleECHO sessions. But I think that the videos that Dr. Rabinovitz mentioned are a wealth of knowledge, and you can just play them over and over again.
So the way I usually do is I tell people just to Google teledermatology in rural Georgia. It'll come right up. And then you go to physician services, and then they'll come up again. And you'll see all those lectures as well as all the TeleECHO sessions. And as I mentioned, the first year were all teledermoscopy, different areas which were covered by mainly Dr. Buchanan last year.
Yeah, I just pulled up your the YouTube. That's looks relatively friendly.
It's
Thank you.
friendly. We're a friendly bunch.
Yeah,
Yeah.
friendly badges.
We are.
Well, thank you. I appreciate that.
Any other
Absolutely.
questions? Okay, if we can, Brenda, you want to just put up the slides for the next session for announcements? So for CME, the CME code, I think, is in the chat, and we'll, we'll get to it. Hold on. Here we are. Okay, so the CME code is there. Our next session is May 6th, and Dr. Buchanan will talk on the red scaly rash, and we'll have a case presentation by Kenji Yoshida, and MCG medical student. And then we will we'll take a 2-month summer break after that, and then come back in August. But we are, we have our next session is May 6th. And I guess I always like to give a reminder to our participating clinics to keep sending your consults into Dr. Buchanan, and I guess people are, and so that is great because that's what this program is all about. So if there are no other questions or comments, we can end the session. A reminder to the TeleDerm Hub people to stay on for a few more minutes, and people from the spoke clinics and other guests can sign off now. So have a good month.